Imagine for a second, right, that it's a Friday night.
Okay.
You're out at a nice bustling restaurant, you're laughing, talking with friends, you take a bite of a steak or maybe a dry piece of chicken and you swallow.
Right.
Only it doesn't go down, it just stops.
Oh, man. That's terrifying.
Yeah, exactly. And it doesn't enter your windpipe, so you can still breathe, like you're not actively suffocating. But there is just this solid mass of food wedged completely tight right halfway down your chest.
Yeah, right in the esophagus.
Right. So you try to swallow water to, push it down, and the water just backs up into your mouth. You literally can't even swallow your own saliva.
Yeah, to total blockage.
It is. And you're in severe, escalating chest pain.
Yeah.
You're sitting at this table in a crowded room and you suddenly realize you have to get to an emergency room immediately to have a doctor physically go into your throat and extract the food.
It is an incredibly traumatic way to discover you have a chronic illness. I mean, it really is.
It sounds like a nightmare.
It's a complete nightmare. But it's a scenario playing out in emergency departments all over the world with increasing frequency right now.
Which is wild. So if you are listening to this, whether you're someone who just, loves unraveling medical puzzles, or maybe you're someone who has struggled with unexplained gut issues, or even a kid who mysteriously refuses to eat, you're gonna want to settle in for this one.
Yeah, absolutely.
Because today we are taking an extensive deep dive into a condition called Eosinophilic Oesophagitis, or thankfully just EoE for short.
Much easier to say.
Way easier. And it might just be the most important, structurally fascinating allergic condition you have literally never heard of.
I would definitely agree with that. The immunology alone here is just, well, it's a complete paradigm shift.
Right. And to help us piece this all together, we are diving deep into the massive 2022 Joint Consensus Guidelines. These are from the British Society of Gastroenterology and the British Society of Paediatric Gastroenterology, Hepatology, and Nutrition.
That's a mouthful, too.
It really is.
Yeah.
We've also got some foundational texts on the immune system to back it up. We're basically going to figure out why this once rare condition is suddenly skyrocketing, how it tricks doctors into misdiagnosing it for years, and how treating it is forcing a total rethink of human allergies.
Because we are looking at a disease that breaks a lot of the traditional rules. Rules about how we think the human body is supposed to react to food and the environment.
Okay, so let's start with the basics, because I think a lot of people hear eosinophilic oesophagitis and their eyes just glaze over from all the Latin.
Sure, yeah.
What is actually happening in the body here, in plain English?
We can decode the name pretty easily, actually. The esophagitis part, well, that simply means inflammation of the esophagus.
Okay, and the esophagus is just the tube, right?
Exactly. It's that heavy-duty muscular tube that acts as a transit highway, basically, connecting your mouth to your stomach.
Just getting food from point A to point B.
Right. And then the eosinophilic part, that tells us the specific culprit that's causing that inflammation.
Okay, so what's an eosinophil?
Eosinophils are a highly specialized type of white blood cell. Evolutionarily speaking, they are a vital part of your immune system that's designed to fight off multicellular parasites. Things like worms, basically.
Wow. Okay. Worms.
Yeah.
Yeah.
And they also play a role in certain allergic reactions. But the key thing here is that in a healthy person, you should essentially find 0 eosinophils hanging around in the tissue of your esophagus.
Because there's literally no reason for a parasite-fighting cell to be stationed in a clean transit tube, if that makes sense.
Right. It's like finding a heavily armed SWAT team standing in your hallway when there's no emergency.
That's a great way to put it.
In EoE, what we see is this dense, totally abnormal infiltration of these eosinophils. They literally pack themselves into the tissue lining of the esophagus.
And what happens when they do that? Do they just take up space?
Oh, no, it's much worse. Because they are designed to destroy foreign invaders, right? So they release these cytotoxic proteins.
What's protein?
Literally toxic granules. And when they release these toxins into the esophageal tissue, they cause massive chronic inflammation.
Jeez. So they're just destroying the local neighborhood for no reason.
Basically, yeah.
Now, I noticed in the research that the medical community has drawn a very hard, incredibly specific line in the sand for what actually counts as EoE. It's not just about, seeing a couple of these cells, is it?
Far from it. It requires an overwhelming presence to get the diagnosis. The definitive gold standard is finding a peak count of 15 or more eosinophils per 0.3 square millimeters of esophageal tissue.
Wow, that is specific.
Very. If a pathologist looks at a sample, right, and they count 12 or maybe 14 in that specific area, and there are no other clear causes, it technically does not meet the criteria for EoE.
Even at 14?
Even at 14. It has to be 15 or higher.
I am always fascinated by how these highly specific diagnostic criteria come to be. I mean, we've had esophagi and we've had food since the dawn of humanity.
Right.
Was, like, Hippocrates writing about people choking on olives because of their eosinophils?
No, and that is actually the most intriguing part of this entire disease.
Again?
It is undeniably a modern phenomenon.
Wait, really? Modern?
Yes. If you search the medical literature before the late 1980s, EoE essentially does not exist. It was barely a blip on the radar.
That's wild.
Yeah, it wasn't distinctly characterized as a unique clinical syndrome until the early 1990s. There were these two researchers, Atwood and Strawman.
Okay.
They were working independently, and they published the first definitive case reports of adults who were having difficulty swallowing, which we call dysphagia.
Right, dysphagia.
And their biopsies showed this incredibly dense eosinophilic inflammation without any other obvious cause.
Okay, I have to push back on that just a bit. When we say a disease didn't exist until the 90s, I mean, is it possible people were always suffering from it, but we just didn't have the microscopic tech or maybe the right billing code to identify it? Or is it genuinely a new illness?
It's a great question, and it's a mix of both. But the epidemiological consensus leans heavily toward it being a genuinely emerging disease.
Yep.
I mean, sure, older endoscopies might have missed it, and perhaps people in the 1950s who ate very slowly just thought they had a narrow throat.
Right, just, oh, Uncle Bob eats slow.
Exactly. But the sheer volume of cases we see now, it cannot be explained by better testing alone. The guidelines highlight a staggering shift.
How big of a shift are we talking?
Well, before 2007, the mean estimate of prevalence was about 15 cases per 100,000 people. Fast forward past 2017, and that estimate jumped to 63 cases per 100,000.
Whoa. That is a massive fourfold increase in just over a decade.
It is, and it's continuing to climb.
So something definitely changed. If it emerged in the 90s, there must have been an aha moment, right? Where doctors realized what they were actually looking at.
Yeah, the real breakthrough came in 1995. There was a researcher named Kelly who was looking at a cohort of 10 children.
Just 10 kids?
Just 10, but they had severe unexplained esophageal eosinophilia. They were vomiting, refusing to eat, losing weight. It was bad.
So what did Kelly do?
Kelly's team tried something radical. They took these kids off all normal food completely and put them on a strict elemental diet.
An elemental diet. Okay, that's not just like a green smoothie, right?
Right.
That's breaking food down to its absolute bare components.
Exactly. It is a purely amino acid-based liquid formula. It contains no intact food proteins whatsoever.
Just chemicals, basically.
Right, just the chemical building blocks of nutrition.
Yeah.
The theory was, well, if this is an allergic reaction to food proteins, removing the proteins entirely should stop the reaction.
And did it?
It worked beautifully. The children's symptoms vanished. And when they biopsied the esophagus, the cellular inflammation had completely cleared up.
Wow. That's amazing.
It was. But the real proof came next. When they reintroduced normal food into the children's diets, the eosinophils swarmed back and the disease flared up again.
So they turned it off and then turned it right back on.
Precisely. That 1995 study proved definitively that EoE is a dietary allergic condition.
Okay, but it's not a condition that hits the population evenly. When I was going through the demographic data in the consensus guidelines, it reads like a very specific profile.
Oh, it is highly specific.
Yeah.
First off, it is roughly 3 times more common in males than in females.
3 times, okay.
Yeah, and we see it predominantly in populations of white ethnic origin, although there is a caveat there.
What's the caveat?
The guidelines caution that historical studies haven't thoroughly investigated other ethnic groups with the same rigor, so we might be missing some nuances there.
Right, the data might just be skewed by who's getting tested.
Exactly. Now, in terms of age, while infants and toddlers certainly get it, the incidence actually rises sharply during adolescence. And it peaks in early adulthood, right around the 3rd or 4th decade of life.
So your 20s and 30s. The thing that really stopped me in my tracks, though, was the genetic component. Like, if I get diagnosed with EoE, what does that mean for the people related to me?
The heritability data is intense. Yeah. Now, it's not a simple single-gene mutation. You don't just inherit the EoE gene in a clean, dominant, or recessive pattern, like eye color.
Oh, okay. So it's more complicated.
It is a complex polygenic trait. It likely involves multiple genetic variations that do things like slightly weaken the barrier function of the esophageal lining, or maybe tweak the way your T cells react to external stimuli.
So a bunch of tiny things adding up.
Right. But when those genetic tweaks combine, the real-world risk is undeniable. If you have an affected brother, your personal risk of developing EoE increases 64-fold.
Wait, 64-fold? That is not a subtle statistical bump.
Not at all.
Yeah.
Fathers of an index case, meaning the first person diagnosed in a family, they have a 43-fold increased risk.
Gee.
And if we look at twins, identical twins have a 41% concordance rate, whereas fraternal non-identical twins sit around 22%. So the genetics really, load the gun, so to speak.
But the environment still has to pull the trigger. And the environment throws some really weird curveballs here. I mean, the data mentions a seasonal variation. People get worse at specific times of the year.
Yes, and this is where the immune system's complexity really shows off. Many patients experience distinct flares in their symptoms, or their biopsy cell counts will just spike during specific seasons.
Which season?
Usually spring and summer. These spikes correlate strongly with higher pollen counts and increased exposure to aeroallergens, things like tree pollen, dust mites, or mold.
Okay, I am really struggling to wrap my head around that mechanically.
It's confusing, I know.
Because if I breathe in pollen, it goes into my nasal passages, my sinuses, maybe my lungs, and I get hay fever, I sneeze. But EoE is in the esophagus. We don't typically inhale our food, and we definitely don't swallow massive lungfuls of pollen. So why is the throat reacting to the air?
It's a brilliant question, and it really points to how interconnected our immune mapping is. You're totally right. You aren't swallowing enough pollen to physically coat the esophageal lining in a meaningful way.
Right.
What's happening is an immune-mediated systemic response. Your body senses the pollen in the airway, and it basically sounds a massive systemic alarm.
Like a full-body panic.
Exactly. And for someone with that genetic predisposition we just talked about, that systemic alarm bell gets crossed. The immune system gets confused, and it sends the eosinophil SWAT team not just to the nose, but specifically into the tissue of the esophagus.
That is wild.
It proves that this isn't just a localized contact allergy. It's a whole-body hypersensitivity disorder that just happens to manifest its most severe damage in this one specific tube.
So the body is essentially having a panic attack about the air, and it takes it out on the throat.
Yeah, that's a pretty good way to describe it.
So we know the genetics, we know the triggers, but let's talk about what this actually feels like for the patient day to day. Because from what I read, diagnosing this clinically is incredibly difficult because the disease is like a master of disguise.
It really is the ultimate clinical chameleon.
Because it presents completely differently depending on how old the patient is, right?
Exactly. If you look at pediatric cases, the symptoms are infuriatingly nonspecific. Well, for toddlers, say around 2 or 3 years old, they might simply present with feeding difficulties. They turn their heads away from the spoon, they spit food out, they throw tantrums at the high chair.
Just general toddler stuff, honestly.
Right, which makes it so hard to catch. Medically, they might show failure to thrive, meaning they are dropping off their growth curves and just not gaining weight.
Which is terrifying for a parent. And the child has literally no way of explaining what's happening. A 3-year-old doesn't have the anatomical vocabulary to say, "Mother, I am experiencing localized eosinophilic inflammation in my upper digestive tract."
No, they definitely don't.
They just know that swallowing hurts. So to them, food equals pain.
Exactly. They learn to avoid the pain by refusing the food. Now, as those kids grow a bit older, around 5 to 7, the symptoms might morph into unexplained vomiting or just vague complaints of feeling sick.
Like a chronic stomach bug.
Yeah. And by the time they hit 9 to 11 years old, you start seeing complaints of chronic abdominal pain, heartburn, and the early signs of food feeling, slow to go down. It's really all over the map.
But when we look at adults, that subtlety completely vanishes, right?
Yeah.
The symptoms become super aggressive.
Much more aggressive. In adults, the hallmark symptoms are dysphagia, that difficulty swallowing, and the food bolus obstruction we discussed at the very beginning.
The restaurant choking scenario.
Right. And the reason for this shift is structural. The esophagus of a 2-year-old is inflamed, sure, but it hasn't had years to build up scar tissue yet.
Oh, so the tissue actually changes over time.
It does. By the time a patient is 25 or 30, that chronic, simmering inflammation has caused significant tissue remodeling. The muscular flexible tube has become stiff and narrow, so dense foods like meats or breads simply get wedged.
But people don't usually just wake up one day at age 30 and start choking, right? Don't they notice things getting worse over time?
They do. But human beings are remarkably adaptable, often to our own detriment. Patients develop complex, subconscious coping mechanisms over years or even decades without ever realizing they are actually managing a disease.
Like what kind of mechanisms?
Well, they might become the slowest eater at the table, always the last one finishing their plate.
I know people like that.
Yeah. Or they might aggressively overchew every bite until it's absolute mush. They often require massive volumes of fluid to wash down every single bite.
So they're physically flushing the food down.
Exactly. Or they might just unconsciously stop ordering steak and switch to softer foods. They normalize it. They tell themselves, oh, I've just always been a slow eater.
Right. They view it as a personality quirk, not a pathology.
Yep. But a good doctor might spot clues if they look at the patient's wider medical history. Because EoE rarely travels alone, does it?
Almost never. If you see an adult complaining of slow swallowing, the next question should always be about their allergic history.
Okay, so looking for other allergies.
Right. EoE is heavily tied to what we call the atopic triad. Patients frequently have a documented history of allergic asthma, allergic rhinitis, which is just hay fever, and eczema.
So skin, nose, and lungs.
Yeah. If a patient has eczema on their skin, asthma in their lungs, and they eat slowly, EoE should be at the absolute top of the diagnostic suspect list. It's all the same hyperactive immune system, just acting out in different organs. But here's where the disguise gets truly deceptive. Even if a doctor suspects an issue in the esophagus, EoE perfectly mimics one of the most common medical complaints in the world.
Acid reflux.
Yes, gastroesophageal reflux disease, or GOA. The guidelines mention a study of over 600 kids with EoE, and a full 30% of them had been previously misdiagnosed with acid reflux.
It's a very understandable misdiagnosis, honestly. Heartburn, regurgitation, chest pain, a sour taste in the mouth. These are classic symptoms of both conditions.
They sound identical.
They do. The problem is that GUARD is incredibly common in the general population, whereas EoE, while growing, is still relatively rare. So a doctor hears heartburn and immediately thinks horses, not zebras. They prescribe an antacid and send the patient home.
But I want to dig into the relationship between these two, because the research suggests it's not just a case of mistaken identity. They actually interact with each other in this bizarre, cyclical way. Can you unpack that? Like, if I have acid reflux, how does that relate to an allergy?
The interaction is fascinating, and it actually works in both directions.
Okay, let's hear the first direction.
Let's look at it first from the EoE side. If you have EoE, those eosinophils are dumping toxic proteins into the esophageal tissue. This damages the muscle layers.
Right. Toxic granule.
Yeah. Now, normal esophagi have organized motility muscular waves that constantly push food and any rogue stomach acid back down into the stomach. But an inflamed, damaged esophagus gets sluggish. The muscles don't contract properly.
So it's like a broken conveyor belt.
Great analogy. So acid splashes up from the stomach, the esophagus fails to clear it, and the acid just pools there. In this scenario, the allergic inflammation actually causes secondary acid reflux.
Okay, that makes sense. The allergy breaks the escalator, so the acid just sits on the steps. But it goes the other way, too.
It does. Let's say you just have standard run-of-the-mill GOD. Your lower esophageal sphincter is a bit loose, and stomach acid frequently washes up.
Just a normal heartburn situation?
Right. Well, that acid is highly corrosive. It physically burns and damages the mucosal lining of the esophagus. It breaks down the tight junctions between the cells, increasing the tissue's permeability.
So it's thinning out the wall.
It basically creates microscopic cracks in the armor.
So the wall is breached.
Exactly. Now, you eat something, say, a piece of bread containing wheat proteins. In a healthy esophagus, those proteins slide right past. But with the armor breached by acid, microscopic fragments of that wheat protein seep deep into the underlying tissue layers.
Oh, no.
Yeah. The immune system spots these foreign proteins where they shouldn't be, panics, and sounds the alarm. Eosinophils rush in to fight the invader, and suddenly your standard acid reflux has triggered a localized allergic disease.
That's a brutal biological loop.
Yeah.
The acid breaks the wall, the food gets in, the food triggers the allergy causes inflammation, the inflammation breaks the muscles, which allows even more acid to pool. It's a vicious cycle.
It's incredibly difficult to break.
And it explains why a doctor can't just listen to a patient's symptoms, guess it's reflux, and call it a day. If you want to know what's actually happening, you have to go in and look. Which leads us to the actual diagnostic process.
Right.
Because guessing based on a stomachache clearly isn't going to cut it. How do gastroenterologists actually prove definitively that a patient has EoE and not just bad reflux?
The absolute non-negotiable requirement for an EoE diagnosis is an upper endoscopy with tissue biopsies. A gastroenterologist brings the patient in, usually administers a mild sedative, and passes a flexible tube with a high-definition camera on the end down the throat.
So they're looking directly at the tissue.
Yes, this allows them to visually inspect the entire length of the esophageal lining.
I'm curious about the visuals, though. We talked about how the tissue remodels and scars over time. Can the doctor actually see that damage on the camera? Does EoE have a specific look to the naked eye?
It does, but it requires a very trained eye, and the signs can be surprisingly subtle sometimes. The macroscopic signs, what you see on the screen, include several hallmark features.
Okay, lay them on me.
First, you might see linear furrows. These are deep, vertical grooves running up and down the tissue, almost like the tracks of a tractor in mud.
That sounds rough.
Second, you often see esophageal rings. These are horizontal ridges that circle the tube. When they are really prominent, the esophagus stops looking like a smooth pink pipe and starts looking like the ridged inside of a vacuum cleaner hose.
Oh, wow.
Gastroenterologists sometimes call this trachealization, because it resembles the ribbed cartilage of the windpipe.
That sounds incredibly uncomfortable, like your throat is literally ribbed. What else are they looking for?
They look for white plaques or exudates. These look like tiny white spots or a yeast infection, but they are actually concentrated, superficial clumps of dead eosinophils just pushing their way to the surface.
So little grades of immune cells.
Yeah, pretty much. And finally, there's a sign called crepe paper esophagus. This is where the mucosal lining is so inflamed and fragile that it literally tears or shears just from the gentle friction of the smooth endoscope sliding past it.
Crepe paper esophagus. That is a vivid, terrifying image. The tissue is literally crumbling under its own weight.
It is extremely fragile tissue.
But here's the catch that blew my mind in the guidelines. Seeing these things isn't enough, and conversely, not seeing them doesn't mean you're safe. The data shows that up to 21% of children who absolutely have biopsy-proven EoE have a completely normal-looking esophagus on camera.
Yes. 1 in 5 kids looks totally pristine to the naked eye. The inflammation is entirely microscopic.
That's crazy.
Which is exactly why visual inspection is merely a suggestion. The golden rule, the absolute bedrock of the international consensus, is the biopsy protocol. The doctor must take physical tissue samples.
And there are rules for that, too. Right.
Very strict rules. The guidelines mandate a specific procedure. They must take at least 6 individual biopsies, and they must harvest them from at least 2 different anatomical sites within the esophagus, usually the distal end near the stomach and the proximal end higher up.
I want to dig into that 6 biopsy rule. It seems so arbitrary. Why 6? Like, if I'm trying to figure out what kind of cake I baked, I don't need to take 6 slices from different sides. I just take 1 core sample, and I know it's chocolate. Why doesn't that work for EoE?
Because of the unique, frustrating spatial nature of this specific inflammation. If we connect this back to the microscopic battlefield, eosinophilic infiltration is famously patchy. Yeah, it does not coat the esophagus in a smooth, uniform blanket of disease. You could have a dense, highly destructive cluster of eosinophils in 1 square centimeter of tissue and completely healthy, perfectly normal tissue right next door.
So taking a biopsy for EoE is less like sampling a uniform cake and more like trying to map out a microscopic minefield. If you only take 1 or 2 samples, you might step right between the mines, declare the area completely safe, and send a sick patient home.
That is the perfect analogy. The 6 biopsy rule from multiple distinct sites is just a statistical necessity. It mathematically maximizes the probability of the tiny biopsy forceps actually hitting an inflamed patch.
Okay, so they get the 6 samples. Then what?
Once they retrieve those 6 tiny pieces of tissue, they send them off to a pathology lab. There they are sliced incredibly thin, stained with dyes, and put under a microscope. And this is where that magic diagnostic number comes into play. The pathologist is looking for a density of 15 or more eosinophils per 0.3 square millimeters.
Right, let's talk about that metric.
Yeah.
The 0.3 square millimeters. The guidelines made a huge point of emphasizing this shift. It used to be measured per high power field, or HPF. Why did the entire global medical community decide to change the vocabulary here?
It's a fascinating reflection of how technology changes medicine. Historically, a high-power field simply meant whatever the pathologist could see when they looked through the physical ocular lens of a traditional microscope at 400x magnification.
Right, like in high school biology.
Exactly. The problem is microscopes are manufactured by different companies. One brand's lens might show a field of view that is 0.2 square millimeters. Another brand's wider lens might show 0.4 square millimeters. It wasn't a standardized unit of physical space.
Oh, I see. So a patient could theoretically be diagnosed with EoE in one hospital, take their slide across town to a hospital with older microscopes, and suddenly not meet the criteria because the circle they were looking through was smaller.
Exactly. It was creating absolute chaos in clinical trials and diagnostic consistency. But over the last decade, Pathology has undergone a digital revolution. Pathologists don't hunch over physical microscopes as much anymore. The glass slides are digitally scanned at incredibly high resolutions, and they examine the images on massive computer monitors.
So the physical lens is gone?
The physical lens no longer exists. So the international consensus standardized the metric to an exact physical measurement of the tissue itself, 0.3 square millimeters. It roughly equates to the old optical standard, but it guarantees absolute uniformity across the globe.
Okay, so the pathologist draws their precise digital 0.3 millimeter box on the screen, and they start counting. But are they only looking for those 15 eosinophils? Because surely there's other collateral damage visible at that microscopic level.
Oh, absolutely. The 15 eosinophils are the gatekeeper threshold, but a good pathologist is looking for a whole constellation of structural damage to confirm the diagnosis. They are looking at the architecture of the tissue. For instance, they look for basal cell hyperplasia.
Break that down for us. What is basal cell hyperplasia?
So the esophagus is lined with squamous epithelium layers of flat cells. The basal cells are the foundational layer at the very bottom. They are basically the factories that produce new cells to replace the ones that naturally slough off the top.
Makes sense.
When the eosinophils attack the surface, they destroy those top cells. The basal cells sense this massive damage and go into absolute panic mode. They start multiplying rapidly, desperately churning out new cells to try and rebuild the wall while it's actively under siege.
Wow.
Under the microscope, this looks like a thickened, hyperactive bottom layer.
The cellular factory is going into overdrive. What else do they see?
They look for spongiosis. This is an accumulation of fluid edema between the individual cells. It physically pushes the cells apart, creating tiny microscopic gaps.
Like swelling, basically.
Yes. And they also look for eosinophil microabscesses, which are exactly what they sound like. They're tiny, localized collections of dead eosinophils and destroyed cellular debris just buried in the tissue. Finding these secondary features proves that the eosinophils aren't just passively floating by, they're actively destroying the neighborhood.
But there is one massive, crucial caveat to this entire highly calibrated diagnostic protocol. And if a doctor misses this, the whole thing just falls apart. The PPI rule.
Yes.
The guidelines are adamant that patients must be taken off proton pump inhibitors, standard over-the-counter acid reflux medications like omeprazole or Nexium, for at least 3 weeks before the endoscopy. Why is that so critical?
Because PPIs are remarkably powerful drugs.
Yeah.
And as we'll discuss in a moment, they possess hidden anti-inflammatory properties that go way beyond just stopping stomach acid.
Oh, interesting.
If a patient is actively taking a PPI during their endoscopy, that drug might be actively suppressing their eosinophil count. Their true baseline count might be 40. But because of the drug, it drops to 10.
And 10 is below the 15 cell threshold.
Exactly. The pathologist counts 10, says it's under 15, you don't have EoE, and the patient is misdiagnosed and sent away, all because they took a heartburn pill that morning. Mandating 3 weeks off the drug ensures the tissue reflects its true, unmedicated baseline state of inflammation.
It makes complete sense. You have to remove the variables to see the real disease. But here's the reality check. This entire 6 biopsy, 3 weeks off meds, carefully mapped out protocol assumes the diagnosis is happening in a calm, scheduled outpatient clinic.
Right. It assumes the system is working perfectly.
It assumes the patient booked an appointment. But as we established at the very beginning, that is often not how this disease introduces itself. What happens when the diagnosis isn't a planned investigation, but a sudden, terrifying crisis?
Yeah, this brings us to the emergency room and the dramatic, often mishandled reality of acute food impaction.
Because this is where the medical system has historically failed EoE patients the most, right?
Without a doubt. For a huge percentage of people, there is no gradual ramp up. No outpatient visits for mild heartburn. The very first time they realize they are sick is the Friday night restaurant scenario, the food bolus obstruction.
And the guidelines note something staggering here. EoE is not just a rare cause of this. It is currently the most common cause of food bolus obstruction presenting to emergency departments today.
It is the #1 cause.
Over 30% of EoE patients discover their disease this way. That's almost a third.
It's massive. Imagine the chaotic environment of an ER on a weekend. A patient comes in, unable to swallow, drooling into a cup, in absolute agony. The on-call gastroenterologist is paged.
And they're probably busy with a dozen other things.
Exactly. Their primary, overwhelming objective is acute crisis management. Sedate the patient, pass the endoscope, physically extract the chunk of meat or push it safely into the stomach, ensure the esophagus hasn't ruptured, and wake the patient up safely.
Which sounds perfectly reasonable. They solve the immediate life-threatening problem. But the new guidelines are basically shouting at ER doctors that this is not enough. They demand that doctors take those 6 biopsies during the emergency removal procedure. Why has this been such a point of contention?
Because historically, gastroenterologists view the ER purely as a rescue mission, not a diagnostic one. They didn't want to spend extra time taking tiny tissue samples in an inflamed, traumatized esophagus at 2.0 a.m.
So they just skipped it.
In the past, studies showed that an unbelievable 73% of patients who came in with an acute food impaction did not get biopsied during the procedure. The doctor just removed the food, patted the patient on the shoulder, and said, make sure you follow up with your primary care doctor in a few weeks to figure out why that happened.
I feel like I can guess the punchline here. Once the terror is over, human nature takes over. They don't follow up.
Exactly. The relief is so profound once the food is gone, the patient feels perfectly fine. They think, oh, I just took too big of a bite. I was eating too fast.
Right.
Almost 80% of those non-biopsied patients were completely lost to follow-up. They skipped the elective outpatient appointment. The result, a massive multi-year delay in getting the actual EoE diagnosis.
That is a catastrophic failure of the medical system to capture the patient when they are right there on the table.
Which is precisely why the guidelines are so forceful now. You already have the camera down the throat. The patient is already sedated. Take the 2 extra minutes to take the 6 biopsies right then and there. It is arguably the single most critical opportunity to catch the disease before it causes permanent damage.
Let's talk about the permanent damage. Because untreated EoE is not a static condition. It's not just a minor annoyance you can ignore. It relentlessly progresses toward what the guidelines call fibrostenotic disease. What does that actually mean?
It refers to the physical remodeling of the esophagus. Let's go back to those basal cells trying to repair the damage.
Cellular factories.
Right. When tissue is chronically inflamed for years, the body's repair mechanisms get exhausted and sloppy. Instead of regenerating healthy, flexible muscle tissue, the body starts laying down rigid collagen. It creates thick scar tissue.
So it's turning into a solid pipe.
Over time, the flexible tube turns into a stiff, narrowed, fibrotic pipe. This narrowing is called a stricture.
And the data on how quickly this happens is sobering. It proves that time literally equals damage.
The statistics are crystal clear. If a patient is fortunate enough to be diagnosed and treated within 2 years of their very first symptoms, their risk of developing a permanent stricture is about 17%.
Okay, not 0, but manageable.
But if the diagnosis is delayed by more than 20 years, which again happens frequently because people just adapt their eating habits, the stricture rate skyrockets to 71%.
71%?
Yes. The majority of those patients will suffer permanent structural narrowing.
And when it gets that narrow, not only does food get stuck, but the tissue itself becomes structurally unsound. The guidelines mention that EoE is actually the most common cause of spontaneous perforation of the esophagus.
A spontaneous perforation is a true worst-case scenario. The tissue becomes so fragile, inflamed, and stiffened that the sheer mechanical pressure of a trapped food bolus, or even the violent pressure of a patient trying to forcefully vomit the food back up, actually tears a hole straight through the esophageal wall.
That sounds immediately lethal.
It is intensely dangerous. But it is important to distinguish an EoE perforation from something like Boerhaave syndrome.
What's Boerhaave's?
Boerhaave's is a massive, often highly fatal rupture of a completely healthy esophagus, usually caused by explosive vomiting. EoE perforations tend to be slightly smaller, more localized tears in already damaged tissue.
So they're a little easier to survive.
They're usually treated conservatively, meaning they don't always crack the chest open for major surgery. Gastroenterologists can often place expanding metal stents inside the esophagus to plug the hole from the inside.
Like patching a tire.
Exactly. They insert internal drains, flood the patient with IV antibiotics to prevent chest infections, and use feeding tubes while the tear slowly heals. It's a massive, agonizing medical ordeal, but it is usually survivable.
But ideally, we intervene before it tears.
Yes, definitely.
If a patient has developed severe, tough strictures, how do doctors mechanically fix it? Because medication can stop the fire, but it can't melt existing scar tissue. The guidelines discuss endoscopic dilation. How does that work?
Dilation is the brute force mechanical solution to a mechanical problem. During an endoscopy, the doctor passes a tool across the narrowed stricture. They either use a deflated balloon, which they slowly pump full of water or air once it's inside the narrowing, or they use a bougie.
A bougie?
It's a solid, tapered plastic tube that gradually gets wider. As they inflate the balloon or push the wider bougie through, it physically stretches the esophagus, applying immense outward pressure to snap and break the fibrotic scar tissue, forcibly widening the lumen.
I have to be honest, stretching a rigid, scarred, fibrotic throat with a high-pressure balloon sounds incredibly violent.
It does.
The tissue is already diseased. Doesn't that risk ripping the esophagus wide open?
It sounds barbaric, and intuitively it feels incredibly risky, and you are correct to a degree. The intention of dilation is to tear the scar tissue.
Well, they want it to tear.
Yes. Minor mucosal tears, superficial ripping of the lining, actually happen frequently. We see them in about 9% of all dilations. The doctors actually want to see a little bit of minor tearing and a trace of bleeding on the camera. It means the rigid scar tissue is successfully yielding to the pressure.
Wow. So the patient wakes up feeling pretty rough.
The patient will certainly have a very sore chest for a few days. But the crucial distinction the data provides is that major, dangerous, full-thickness perforations tearing a hole all the way through are exceedingly rare.
How rare?
A massive meta-analysis looking at over 1,800 individual dilations showed a major perforation rate of just 0.38%. When performed by a skilled physician, it is remarkably safe, and the payoff is huge. It boasts a 75% immediate clinical improvement in the patient's ability to swallow.
It's an incredible intervention. But the guidelines are very, very explicit on one point. A doctor cannot just dilate. That is not a complete treatment.
If we look at the bigger picture, dilation is treating the symptom, not the cause. It physically breaks the scar tissue, but it does absolutely nothing to stop the underlying eosinophils from dumping toxins.
Because the immune system is still freaking out.
Exactly. If a doctor just stretches the throat and sends the patient home with no further treatment, the active inflammation will immediately start laying down new collagen, rebuilding the scar tissue. Within a year, the patient will be right back on the table for another dilation.
So it's just a temporary fix.
Right. Dilation must be paired with aggressive anti-inflammatory therapies to stop the disease process and prevent immediate relapse.
Okay, so you've navigated the ER, you have your 6 biopsies, your 0.3 millimeter cell counts, maybe you've had a balloon stretch your throat, and you have your definitive diagnosis. Now you actually have to go home and live with EoE. You have to treat it.
Yes, the long-term management phase.
And logically, if this is an allergic reaction to food, the most intuitive, natural answer is simply to stop eating the food that causes it. Which brings us to the complex, deeply frustrating world of dietary management.
Diet therapy is arguably the most fundamental approach to treating EoE because it addresses the root cause directly. But it is also, without a doubt, the most psychologically taxing and socially isolating path a patient can take.
Let's start with the most counterintuitive, baffling statement in the entire 2022 guidelines. I read this 3 times to make sure I wasn't misunderstanding.
Let me guess. Allergy testing.
Yes. Standard allergy tests, like skin prick tests where they put little drops on your arm, blood tests for specific IgE antibodies, those grid patch tests they tape to your back. The guidelines explicitly, in bold text, state they are not recommended for trying to figure out what food is causing a patient's EoE.
They absolutely do not work.
Why on earth wouldn't you use an allergy test to find an allergy? It seems crazy.
It is a massive paradigm shift, and to understand it, we have to look at the 2 very different ways the human immune system handles allergies.
Okay, break it down.
Most people are familiar with classic IgE-mediated allergies. Immunoglobulin E. If you have an IgE peanut allergy and you eat a peanut, your body's IgE antibodies instantly recognize the peanut protein. Within seconds, they trigger mast cells all over your body to dump massive amounts of histamine.
And that's when things get bad fast.
Your airways close, your blood pressure drops, you break out in hives, you go into anaphylactic shock in 5 minutes. It is an immediate, explosive, life-threatening detonation.
And that's what a skin prick test is looking for. They prick your arm with peanut extract, and within 10 minutes, the skin puffs up into a giant red mosquito bite. The explosion happens right on your arm.
Exactly. But EoE operates on a fundamentally different immune pathway. It is primarily a non-IgE-mediated condition.
Meaning no mast cell explosions.
Right. It doesn't rely on those explosive mast cells. Instead, it appears to be heavily driven by a different antibody, Ig4, and a very slow, delayed T-cell response. Because it doesn't use the explosive IgE pathway, those standard scratch tests and IgE blood panels are completely useless.
Your body's immediate anaphylaxis alarms just don't go off.
Exactly. The damage in EoE is a slow, localized, insidious invasion that takes days or weeks to build up.
So using a traditional scratch test to find the cause of EoE is like using a metal detector to search for plastic explosives. You might be scanning the right area, but you are looking for a completely wrong biological signal. The machine will just beep at random things and miss the actual threat entirely.
That is a perfect analogy. Studies show that using skin prick tests to guide EoE diets was barely more effective than just flipping a coin. It resulted in patients needlessly removing safe foods while continuing to eat the actual triggers.
That sounds incredibly frustrating for the patient.
So if we can't test for the trigger with a needle or a blood draw, we are forced to play dietary detective. We have to use empirical elimination diets. We remove suspected foods, check the tissue, and see if it gets better.
And the heavyweight champion of these detective diets is the SFE, the six-food elimination diet. Walk me through this gauntlet.
Developed in the mid-2000s, the SFED is a brute force approach. It empirically removes the 6 most common, highly allergenic food groups in the Western world all at once.
All at once. Okay, what are they?
The patient must completely eliminate cow's milk, wheat, egg, soy, all nuts, both tree nuts and peanuts, and all fish and seafood.
That is basically the entire center aisles of the grocery store. Does it actually work?
Biologically, brilliantly, it boasts a 79% histological remission rate. Nearly 8 out of 10 patients who strictly follow this diet will see their eosinophil counts drop well below that 15-cell diagnostic threshold. Their esophagus heals.
But the human catch is nobody can sustain that. You try going out to a restaurant and saying, I'll have the meal, but hold the dairy, wheat, eggs, soy, nuts, and fish. You're going to get a plate of plain lettuce and ice water.
The adherence rates outside of clinical trials are terrible. And frankly, you cannot blame the patients. It is utterly socially crippling. But the initial elimination is only half the nightmare. The real misery is the reintroduction phase.
Right, because you don't want to avoid all 6 forever if you're only allergic to one.
Exactly. To figure out which of those 6 foods is the actual culprit, you have to add them back one at a time. The patient adds milk back into their diet every day for 8 weeks. Then they must undergo another sedated endoscopy with 6 biopsies to check the tissue.
Another scope.
Yes. If it's clear, milk is safe. Then they add wheat for 8 weeks. Another endoscopy. A single patient might require 6 or 7 separate invasive endoscopic procedures over the course of a year and a half just to finally discover they are only reacting to dairy.
That is an unbelievable burden on the patient and a massive drain on the healthcare system's resources. So what is the alternative? Because the guidelines clearly recognize that the SFE is too much for most people.
The consensus has shifted to strongly recommend a step-up approach. Instead of starting with a nuclear option of 6 foods and working our way down, we start small and work our way up. The guidelines advocate beginning with a 2-food elimination diet.
Which 2?
In Western populations, epidemiological data shows that the 2 overwhelming culprits driving EoE are cow's milk and wheat, so the patient cuts just those 2.
Which is still hard. No pizza or cheeseburgers, but it's vastly more manageable than cutting soy and eggs, too.
Precisely. After 8 to 12 weeks on the 2-food diet, they have an endoscopy. Around 43% of patients will achieve full remission just by dropping milk and wheat. If they're in remission, great. We test milk, then test wheat, and we're done. They only need a couple of endoscopies.
And if the 2-food elimination fails, if the eosinophils are still swarming,
then, and only then, do we step up. We move them to a 4-food elimination, usually keeping milk and wheat out and adding egg and soy to the ban list. We wait 8 weeks and test again.
And if that fails, you go to 6.
If that fails, we finally step up to the full 6-food elimination. This step-up approach is brilliant because it prevents over-restricting patients right out of the gate. Global data shows it reduces the total number of endoscopies required across the patient population by 20%, and the psychological burden is drastically lighter.
I want to touch on something you mentioned back in the history section, the elemental diet. The purely liquid amino acid formula that Kelly used in the 1995 study, is that still used today?
It is, but it is considered the absolute nuclear option. From a purely biological standpoint, elemental diets are nearly flawless. They are 90% effective at inducing total remission because they remove all intact proteins. The immune system simply has nothing to lock onto and react to.
But the human reality of it is grim.
The human reality is devastating. The formulas are incredibly expensive. They taste notoriously terrible, often described as tasting like chalky chemicals, and the quality of life impact is severe. You cannot eat any solid food, period.
That's rough.
In severe pediatric cases where kids are failing to thrive and nothing else works, doctors sometimes have to resort to surgically placing a PEG tube, a feeding tube, directly through the abdomen into the stomach, just to pump these liquid formulas into the child while they sleep to maintain basic nutrition. It is highly effective biology, but an incredibly traumatic daily reality.
Which highlights a very specific, bolded mandate in these guidelines. If a doctor is going to attempt any dietary therapy for EoE, a specialist dietitian is considered mandatory. It's not optional.
You cannot simply hand a pamphlet to a mother and say, don't feed your child milk, wheat, egg, or soy, and send them out the door. Those foods are the foundational building blocks of the Western diet. Dairy provides crucial calcium, vitamin D, and protein. Wheat provides essential B vitamins and iron.
Right. You can't just delete them and not replace them.
If you blindly remove these from a child's diet without expert, meticulous guidance on how to replace those specific micronutrients with safe alternatives, you risk causing severe malnutrition, vitamin deficiencies, and permanent stunting of the child's physical growth and bone development. A registered specialist dietitian is a non-negotiable anchor of the EoE care team.
But here is the reality of human behavior. Because the dietary path requires such immense monastic discipline, carries real nutritional risks, and involves multiple invasive endoscopies just to see if it's working, a lot of patients say, I can't do this, give me a pill.
Yeah, they want a medical solution.
Yeah, they turn to the medicine cabinet. Which brings us to the pharmacological treatments for EoE. And this features one of the most bizarre, fascinating plot twists I have ever seen in modern pharmacology. I'm talking about the PPIs.
The proton pump inhibitors. It's a brilliant story of accidental scientific discovery.
We just talked about how PPIs, drugs like omeprazole or pantoprazole, are used to treat standard acid reflux. They shut down the pumps in the stomach that make acid. Why on earth are they the first-line recommended treatment for an allergic immune-mediated disease of the esophagus?
For a long time, the medical community was just as confused as you are. Historically, doctors believed that if a patient had eosinophils in their esophagus, but those eosinophils disappeared when they took a PPI, the patient didn't actually have EoE. Yeah. Doctors assumed the patient just had incredibly severe acid reflux that was burning the esophagus so badly it was causing secondary eosinophilic inflammation. They actually created a completely separate diagnostic category for it. They called it PPI-responsive esophageal eosinophilia. They thought it was a totally different disease from true allergic EoE.
Because the logic was, if an antacid cures it, it must have been an acid problem. But the 2022 guidelines throw that entirely out the window.
Completely out the window. Extensive molecular and genetic transcriptomic profiling, literally looking at how the genes in the tissue are expressing themselves, has proven definitively that EoE that responds to a PPI is the exact same genetic and allergic disease as EoE that does not. The eosinophils are the same, the tissue damage is the same.
Okay, then the million-dollar question, how does an antacid fix an allergy?
It turns out PPIs have been hiding a massive secret. They don't just stop stomach acid. They possess hidden, independent anti-inflammatory properties that have absolutely nothing to do with stomach pH. Specifically, researchers discovered that PPI molecules can directly block the expression of a chemical called eotaxin 3 within the epithelial cells of the esophagus.
What is eotaxin 3? Why does blocking it matter?
Eotaxin 3 is a chemokine. Think of it as a highly specific chemical homing beacon or flare. When the allergic esophagus is exposed to wheat or milk, it panics and secretes large amounts of eotaxin 3 into the surrounding tissue. This chemical signal drifts into the bloodstream and acts like a magnet, specifically calling eosinophils to exit the blood and swarm into the esophageal tissue.
Oh, wow. So if the PPI blocks eotaxin 3, it's essentially jamming the radio signal. The esophagus might still be allergic to the wheat, but it can't broadcast the SOS signal to the immune system. The eosinophils never get the memo to attack.
That is exactly it. A common, cheap, over-the-counter heartburn pill acts as a highly effective localized immune jammer. And it works beautifully for a lot of people. The guidelines show that high-dose PPI therapy, such as taking omeprazole 20 milligrams twice a day for 8 to 12 weeks, induces complete histological remission in roughly 50% of EoE patients.
So it's basically a coin flip that a really easy one to try.
Exactly. It's essentially a coin flip, but it's a very safe, incredibly accessible first step before a patient has to attempt a grueling elimination diet.
But it is a coin flip. For half the patients, the PPI doesn't jam the signal enough, and the eosinophils keep attacking. When the heartburn pills fail, the guidelines say it's time to bring out the heavy artillery. topical steroids?
Corticosteroids are the most potent, broad-spectrum anti-inflammatory medications we have. They don't just jam one signal. They shut down the entire inflammatory cascade at the cellular level. In EoE, the standard of care is using swallowed topical corticosteroids, specifically molecules like fluticasone or budesonide.
Wait a second. Fluticasone, budesonide. Anyone with asthma knows those names. Those are the exact same medications used in standard asthma inhalers. But asthma inhalers are designed to be breathed deep into the lungs. How do you use them to treat the esophagus?
That structural mismatch was a huge hurdle in the early days of treating EoE. Doctors knew the steroid worked, but they didn't have an easy way to deliver it to the throat. So patients were originally given bizarre, hacky instructions.
Like what?
They were told to take their asthma inhaler, puff the aerosol into their mouth, but instead of inhaling deeply, they had to forcefully swallow the mist, often followed by a tiny sip of water.
That sounds impossible to do, right?
It was incredibly clunky. Most of the medicine ended up in the lungs or the stomach anyway, and it was hard to dose correctly.
Have we improved on the swallow your inhaler method? Because that sounds terrible.
Thankfully, yes. Pharmaceutical companies finally recognized the massive need and developed specific, targeted formulations for the esophagus. For adults, we now have orodispersible budesonide tablets. These are brilliant little pills that you place on your tongue. They slowly melt over a few minutes, mixing with your saliva to create a concentrated steroid liquid that naturally coats the esophagus as you swallow continuously.
That is so much smarter. But what about for kids? Getting a 5-year-old to hold a melting pill on their tongue sounds impossible.
For children, doctors rely on compounding pharmacies or parents to create an oral viscous slurry. They take liquid steroid ampules, the kind usually meant to be put into a nebulizer machine, and mix them with something thick and sticky, like honey, maple syrup, or a specific sugar substitute like Splenda.
Oh, to make it thick.
Right. This creates a thick, medicated syrup. The child swallows it, and because it's viscous, it oozes slowly down the throat, painting the inflamed tissue with steroids rather than just washing quickly into the stomach.
I love that. So patients are literally hacking asthma medication, mixing it with honey, to create a localized fire extinguisher for their throat. It's brilliant because it keeps the medicine exactly where it's needed, instead of setting off the body's entire systemic sprinkler system by taking steroid pills.
That localized delivery is the entire goal. We want massive anti-inflammatory power applied directly to the esophageal tissue, with absolute minimal absorption into the main bloodstream. And the clinical results are spectacular. The landmark phase 3 trials for those budesonide melting tablets show that they achieved up to 84% clinical and histological remission.
84%.
Yes. For the vast majority of patients who use them properly, the dysphagia disappears, the pain stops, and the eosinophils vanish from the biopsies.
It sounds like a miracle drug. But I was reading the long-term data, and there's a very heavy catch. It's not a cure, it's just a pause button.
It is strictly a maintenance therapy. The guidelines are intensely adamant about communicating this to patients. Clinical and histological relapse is almost guaranteed if the topical steroids are stopped.
Almost guaranteed.
Yes. A massive trial followed patients who had achieved full remission on budesonide. They took half the group off the drug. The median time to full relapse of the disease was just 87 days.
Less than 3 months.
Right. The group that stayed on the drug maintained their remission for over a year. You have to keep applying the fire extinguisher every single day, or the fire inevitably comes back.
Which raises an obvious concern. If a 20-year-old is diagnosed, they might be coating their throat in steroids every day for the next 60 years. What are the long-term side effects of that?
Because the application is highly localized and topical, the dreaded systemic side effects of steroids, things like severe bone density loss, adrenal gland suppression, cataracts, or major weight gain, are incredibly rare.
That's a relief.
The drug is broken down by the liver very quickly if it does get absorbed. The guidelines do recommend periodically monitoring bone density in growing children on long-term therapy, just out of an abundance of caution. But it's generally very safe systemically.
But there are localized side effects, right?
Yes. The primary side effect is entirely localized to the mouth and throat. Oral candidiasis, commonly known as thrush, it's a yeast infection. Steroids suppress the local immune system in the throat to stop the eosinophils, but that suppression allows naturally occurring yeast to overgrow. It happens in up to 22% of patients taking swallowed steroids.
A yeast infection in your throat sounds miserable. Does that mean they have to stop the EoE treatment?
No, and that's a key point. It's an annoyance, certainly causing some soreness or white patches in the mouth, but it is easily and rapidly treated with standard antifungal mouthwashes or lozenges. Crucially, the guidelines state that patients usually do not have to stop taking their life-saving EoE steroids while treating the transient thrush.
Before we move on from medications, I want to briefly touch on what the guidelines explicitly say does not work. Because when people hear they have an autoimmune or allergic disease, they immediately jump on Google and start looking for the latest modern miracle drugs or reaching for the Benadryl.
The guidelines draw a very hard evidence-based line here to prevent doctors from prescribing useless, expensive, or actively dangerous treatments. First, as we just discussed, systemic steroids, taking prednisone pills, or getting steroid injections are strongly not recommended for routine management.
Because of the side effects.
Right. The side effect profile of systemic steroids is simply too severe to justify for a disease localized to one organ.
What about the biologics used for other gut diseases, like Crohn's disease?
Classic biologic drugs used for inflammatory bowel disease, like the anti-TNF drugs infliximab, for example, or broad immunomodulators like azathioprine, simply do not work for EoE.
Why not?
IBD is driven by a completely different inflammatory pathway. It's often Th1 or Th17 driven, whereas EoE is a Th2 driven allergic disease. Using Crohn's drugs for EoE is like bringing a wrench to fix a software bug. It's the wrong tool.
Good analogy.
And finally, taking standard over-the-counter allergy pills, antihistamines like Zyrtec or Claritin, or asthma drugs like montelukast show absolutely zero benefit in treating the esophageal inflammation. If you have hay fever, take them for your nose, but they won't save your esophagus.
Okay, so we've covered the microscopic invasion of the cells, the physical tearing of strictures, the horror of food impactions, the grueling diets, and the melted steroid tablets. But treating a chronic disease is never just about cell counts and pill boxes.
No, it's really not.
It's about a human being trying to navigate the real world and a healthcare system for the rest of their life. Which brings us to the final and perhaps most important aspect of this deep dive. Let's talk about the human element, the psychological toll, and where the future of this disease is heading.
The psychological impact of EoE is profound, and for a long time it was largely ignored by gastroenterologists who were solely focused on the tissue. The 2022 guidelines finally dedicate significant formal recognition to the mental health burden, particularly regarding dietary therapy.
I can only imagine. Eating is the most fundamental, universal social activity human beings share. We celebrate with food, we mourn with food, we date over food, we do business over food. When you severely restrict what someone can eat or make the act of swallowing a source of terror, you are isolating them from society.
Precisely.
Yeah.
Imagine being a 10-year-old child. You're invited to a birthday party. You cannot have the pizza. You cannot eat the birthday cake. You cannot share the snacks at the sleepover. You have to bring your own special Tupperware of safe food and explain to every single adult why you aren't eating.
That sounds miserable for a kid.
It is. Or imagine an adult professional who dreads going to business dinners because they fear choking in front of their boss or having to interrogate the waiter about the exact cross-contamination protocols in the kitchen.
It's a constant, exhausting hypervigilance.
The studies cited in the guidelines report remarkably high rates of anxiety, depression, and social exclusion, particularly in older women and adolescent children. Children on restricted EoE diets report significant problems at school, chronic sleep difficulties, and generalized anxiety disorders.
I mean, the mental load must be huge.
The sheer mental load of constantly monitoring every single bite of food, reading every label, and fearing a medical emergency is exhausting. This is why the guidelines now stress that psychological support and counseling are increasingly recognized as a vital, necessary component of comprehensive EoE care, not just an optional add-on.
And there is a specific, highly dangerous logistical vulnerability highlighted in the text regarding these younger patients, the transition of care.
Moving from pediatric care to adult health care is a massive vulnerability point for any chronic childhood disease, but it is acutely dangerous in EoE.
Why is that?
Consider the dynamic in pediatric care. The parents are acting as the project managers. The parents manage the restrictive diet, they ensure the steroid slurries are taken every morning, they schedule the constant endoscopies, they advocate for the child. The pediatric gastroenterologist is usually very nurturing and hands-on.
Right. And then they grow up.
Then the patient turns 18, they graduate high school, they go off to college or start working, and suddenly they were transferred to an adult gastroenterologist.
And the adult system operates very differently, doesn't it?
Completely differently. The adult doctor expects the 18-year-old to be fully independent, to manage their own prescriptions, book their own scopes, and strictly adhere to their diet with literally no parental supervision.
Handing a teenager the total responsibility for a complex, fragile, highly restrictive medical routine is like handing them the keys to a commercial airplane without a manual. They are going to crash. If the medical system doesn't actively bridge that gap, all the healing achieved in childhood is going to be wasted.
And the clinical data backs up your exact fear. Adolescents in transition frequently rebel. They are tired of being different. So they drop their medications, they start secretly eating pizza and wheat because they want to fit in at college.
Which is totally understandable for a teenager.
It is. They skip their follow-up endoscopies because they don't want to deal with it, and a year later they end up right back in the emergency room with a severe food bolus obstruction and new scar tissue.
That's tragic.
The guidelines emphatically stress the need for formal, structured transition programs. Clinics need to actively assess a teenager's psychological readiness and health literacy, slowly transferring responsibility to them over years before just tossing their medical file to the adult clinic.
That transition is crucial. But I want to end on a hopeful note. Because right now, listening to this, the standard of care sounds grim. You are either swallowing asthma steroids every day for the rest of your life, or you are avoiding basic foods like wheat and dairy forever. And all of this is punctuated by getting knocked out with sedatives for an invasive endoscopy every few months just to see if it's working. Please tell me the future of EoE treatment looks better than this.
The future actually looks incredibly bright. We are on the precipice of a revolution in how we manage this disease, moving rapidly toward what we call precision medicine.
Let's talk about the drugs first. You mentioned that the old broad-spectrum biologics for Crohn's disease failed, but there are new biologics making headlines.
Yes, the novel monoclonal antibodies. While older drugs use a sledgehammer approach to suppress the whole immune system, these new drugs act like microscopic sniper rifles. We are talking about drugs like dupilumab, cendakimab, and benralizumab.
How do they work? What are they sniping?
They are targeting specific interleukins. Interleukins are highly specialized chemical messengers that immune cells use to communicate. Specifically, EoE is driven by interleukins like IL-4, IL-13, and IL-5.
So they're targeting the actual communication signals?
Exactly. These are the exact inflammatory text messages that tell the body to recruit eosinophils and start remodeling the tissue. These new biologic drugs bind directly to those specific interleukins, or their receptors, neutralizing them.
And it works.
By blocking just these tiny specific pathways, clinical trials are showing massive, sustained reductions in both the physical symptoms of dysphagia and the microscopic eosinophil counts, completely sparing the rest of the immune system from suppression. We are finally moving away from the blunt instruments of cutting out 6 food groups and toward highly targeted molecular therapy.
That is incredible. But what about the monitoring? Having to be sedated, intubated with a camera, and biopsied just to see if your diet or your new biologic drug is working is a massive, expensive bottleneck.
This is the second revolution on the horizon, and might be even more impactful for daily quality of life. Non-endoscopic testing. The guidelines highly anticipate the rollout of tools like the cytosponge and the esophageal string test.
The cytosponge, I read about this, and it sounds like science fiction. Explain how this works.
It is brilliant in its simplicity. The cytosponge is a small capsule, about the size of a standard vitamin pill, attached to a long, thin, flexible string. The patient sits in a standard clinic chair, holds the end of the string, and swallows the pill with a glass of water. The pill travels down the esophagus and rests in the top of the stomach.
Okay, so you have a string hanging out of your mouth. Then what?
Over the next 5 to 7 minutes, the outer gelatin capsule dissolves in the warm stomach acid. Inside the capsule is a tightly compressed, medical-grade sponge. Once the capsule melts, the sponge expands to about the size of a large coin.
Oh, I see where this is going.
Then the nurse simply takes the string and gently, steadily pulls the expanded sponge back up through the esophagus and out the mouth.
And as it drags up the esophagus, it's scraping the walls.
Exactly. It acts like a microscopic net, collecting over 1 million cells from the entire length of the esophageal lining as it passes. The nurse snips the sponge off the string, drops it in a preservative fluid, and sends it to the pathology lab where they can count the eosinophils directly from the sponge.
That is an absolute game changer. No sedation, no fasting for 12 hours, no operating room, no recovery time. Just swallow a pill on a string, pull it up, and you have your exact cell count.
It takes 10 minutes in a regular doctor's office. It will completely revolutionize patient compliance, drastically lower healthcare costs, and radically reduce the psychological dread and physical risk associated with constant, lifelong endoscopic monitoring.
Okay, we have covered a massive, complex landscape today. Let's do a rapid-fire recap for anyone whose head is spinning.
Sounds good.
Eosinophilic Oesophagitis, or EoE, is a rapidly rising, non-IgE-mediated allergic condition. It tricks the immune system into sending parasite-fighting eosinophils to swarm the esophagus. Those cells cause chronic inflammation, which over time turns a flexible, muscular tube into a stiff, scarred, fibrotic pipe.
Right.
It acts like a clinical chameleon, masking itself as standard acid reflux in kids, but presents as terrifying emergency room food impactions in adults. Diagnosis requires strict adherence to a 6-biopsy rule for multiple sites, measured in a precise 0.3 millimeter box, performed while the patient is absolutely completely off acid blockers.
Exactly.
Treatment is a delicate, often highly frustrating dance. It involves step-up elimination diets guided by dietitians, magical anti-inflammatory PPIs that jam immune signals, and asthma steroids creatively swallowed like syrup to coat the throat.
It is a profound clinical challenge requiring immense patience from both the doctor and the patient. But as we've seen with the advent of specific biologics and the cytosponge, the medical community is mapping this battlefield with incredible, increasing precision.
But as we pull back from the microscopic view of interleukins and basal cells and step away from the daily dietary struggles of these patients, I want to leave you with a massive, looming question that this entire deep dive points toward.
Yeah.
The epidemiological data in these guidelines cites it clearly. EoE essentially didn't exist in the medical literature before the 1980s. Now, its incidence is exploding globally, running in parallel to massive rises in other autoimmune and allergic diseases. Think about the esophagus for a moment. It is a heavy-duty, muscular tube. It evolved over millions of years to handle abrasive roots, tough fibrous meats, hot liquids, and the occasional splash of concentrated stomach acid. It's supposed to be the body's armor.
It's built to take a beating.
Right. So if our esophagi are suddenly becoming highly sensitized, if they're suddenly treating everyday foundational human foods like milk and wheat as toxic, invading threats that must be attacked by white blood cells, what does that say about our modern environment? Is the sudden explosive rise of EoE just a quirky new gastroenterological disease? Or is it the canary in the coal mine for a fundamental, terrifying shift in the human immune system's relationship with the modern world?
It is the ultimate question of modern immunology, and it's one that researchers will be trying to untangle for decades to come.
It is definitely something to mull over the next time you sit down to dinner. Thank you for joining us on this deep dive into the murky, fascinating waters of diagnostic medicine. Keep exploring, keep questioning, and as we've learned today, please chew your food carefully.